After doing examination, next step is laboratory diagnosis, for which, we need following lab reports. 1. CBC with platelet count, and differential, a complete blood count, CBC, is necessary to assess the level of blood loss. CBC should be checked frequently Q4 to 6 hours, during the first day. 2. Hemoglobin value, type and crossmatch blood. The patient should be crossmatched for 2-6 units, based on the rate of active bleeding. The hemoglobin level should be monitored serially in order to follow the trend. An unstable HB level may signify ongoing hemorrhage, requiring further intervention. 3. LFT, to detect underlying liver disease. 4. RFT, to detect underlying renal disease. 5. Calcium level, to detect hyperparathyroidism, and in monitoring calcium in patients receiving multiple transfusions of citrated blood. 6. Gastrin level. 7. The bun to creatinine ratio, increases with upper gastrointestinal bleeding. A ratio of greater than 36 in a patient without renal insufficiency is suggestive of upper gastrointestinal bleeding. 8. The patient's prothrombin time, PT, activated partial thromboplastin time, and international normalized ratio, INR, should be checked to document the presence of a coagulopathy, prolongation of the PT based on an INR of more than 1. 5th may indicate moderate liver impairment. 10. A fibrinogen level of less than 100 mg per deciliter also indicates advanced liver disease with extremely poor synthetic function. Endoscopy. It is the initial diagnostic examination for all patients, presumed to have upper GI bleed. Endoscopy should be performed immediately after endotracheal intubation, if indicated, hemodynamic stabilization, and adequate monitoring in an intensive care unit (ICU) setting have been achieved. Imaging includes 1. Chest X-ray. Chest radiographs should be ordered to exclude aspiration pneumonia, effusion, and esophageal perforation. 2. Abdominal X-ray. Erect and supine films should be ordered to exclude perforated viscous and ileus. 3. Computed tomography, CORT, scanning and ultrasonography may be indicated for the evaluation of liver disease with cirrhosis, cholecystitis with hemorrhage, pancreatitis with pseudocyst and hemorrhage, aortoenteric fistula, and other unusual causes of upper GI hemorrhage. 4. Nuclear medicine scans may be useful in determining the area of active hemorrhage. Angiography. Angiography may be useful if bleeding persists. An endoscopy fails to identify a bleeding site. Angiography, along with transcatheter arterial embolization, TE, should be considered for all patients with a known source of arterial upper GI bleed that does not respond to endoscopic management, with active bleeding and a negative endoscopy. In cases of aortoenteric fistula, angiography requires active bleeding, 1 ml per minute, to be diagnostic. A nasogastric tube is an important diagnostic tool. This procedure may confirm recent bleeding, coffee ground appearance, possible active bleeding, red blood in the aspirate that does not clear, or a lack of blood in the stomach. Active bleeding less likely but does not exclude an upper GI lesion. Benefits of lavage. 1. Better visualization during endoscopy, to give crude estimation of rapidity of bleeding. 3. Prevent the development of portosystemic encephalopathy and cirrhosis. 4. Increases pH of stomach, and hence, decreases clot desolation due to gastric acid dilution. 5. Tube placement can reduce the patient's need to vomit. Note: during gastric lavage, use saline and not use large volume of to avoid water intoxication. Gastric lavage should be done in alert and cooperative patient to avoid bronchopulmonary aspiration. How will we assess severity of upper GI bleeding? We will use a scoring system called Rockall Score. This scoring system has 5 parameters: age, comorbidity, shock, source of bleeding, stigmata of recent bleeding. A total score of more than 8 indicates high risk of death. A total score of less than 3 indicates excellent prognosis.